I would like to give her this platform so that she can come and tell us more on her line. Welcome, Dr. Catherine Ngugi.
Our chief guest, Chief Administrative Secretary, Minister of Health, Dr. Mase Mwangangi, our Chair, Madam Marjorie Siparo, Chair of Health Committee of the Council of Governors, joining us virtually, Professor Nyang Nyongo, Country Director, PEPFAR, Dr. Tamu Daniels, Executive Director, UNAIDS, Dr. Winnie, President and CEO of ECPAF, Chief Lyons, Dr. Medin, UNAIDS representatives, WHO Representative Kenya, Dr. Rudy Eggers, Dr. Masha, Ruth CEO NACC, Board of the National AIDS Control Council, government officials, county representatives, all people living with HIV, distinguished guests, ladies and gentlemen, all protocols observed. Good morning. Good morning again. That was better. It's my great pleasure to be here today to participate in the 6th Maisha HIV and AIDS Conference 2021. I appreciate the National AIDS Control Council under the leadership of our chair and the CEO, Dr. Masha, for creating this platform that allows us to share strides made in HIV and AIDS epidemic control in Kenya, as well as deliberate on challenges that continue to hamper our goal attaining zero new HIV infections. This year's theme, Towards the Last Mile, Resilience and Innovation, is timely, reminding us of the resilience in each one of us to fight against HIV and AIDS, and now fighting a second pandemic, COVID-19. Ladies and gentlemen, today marks a great day in our calendar, demonstrating the collaboration and partnerships among various governments, multilateral and bilateral, civil society organizations, and partners with regard to the HIV and AIDS response in our country. The 3-day program brings together top-notch scientists, innovators, activists, programmers, and other stakeholders to share knowledge and evidence during these unprecedented times. But we hope it will not only serve a solutions-oriented platform, but remind us of the numerous scientific breakthroughs and address the critical issues surrounding our collective response. Thanks, Chair, for reminding us that it's not only about finishing the 3-day meeting, but ensuring that the discussions we'll have here, that we'll go and implement them, but not just state them in paper. Let me take a moment and reflect on the fruits of the journey of the 40 years of resilience in the fight against HIV and AIDS. And I'll reiterate what our CAS, Dr. Mwangangi, has stated. We know we are number 4 in the sub-Saharan Africa, and even in Africa, with the highest number of people living HIV in the world. But we have made great strides. And I think when you saw the chart, Dr. Masha was showing out, for the last 37 years, we have really made great strides. But we still know that when we compare our adolescents and young persons, the new HIV infections affects more, almost to 62%, 15 to 24 years. And Ruth, we hear you out, Remo, and I really call out on all partners to ensure that at the table we have a seat dedicated for the adolescents and young persons. Because I can tell you, for the time I've been the head of NACC, when we have tried implementing the many strategies and interventions that we have had for the years, it's not working for that group. We have to go back to the drawing table. And I really call upon each one of us to have a seat for adolescents and young people on the table. We continue to press on. Out of the 1.5 million, we have 1.2 who are on treatment. But definitely we are missing 300,000. And I really feel more so for children who are less than 14 years old, who don't have the voice, that we have to be the voice for them. The children, adolescents, and adults have the past 3 years been put on optimized regimens to ensure faster viral suppression achievement. We appreciate the multilateral and bilateral support, not only in the commitment in HIV response, but continued support over the years. As a ministry, we greatly appreciate the contribution of each of your efforts towards these tremendous achievements, as well as support from our development and donor partners. Even though we have geographical unique gaps and population gaps, if we work together, we can achieve more and let our generation and future generations live fulfilling life without being limited by the HIV. The current global COVID-19 pandemics have greatly challenged the positive gains made towards achieving HIV epidemic control. Prevention services have really been greatly affected due to the reduction in community outreaches, specifically on voluntary medical male circumcision, key population outreaches as well. Community HIV testing services have also been greatly affected. In fact, it reduced with more than 72%. Access to health facilities was greatly reduced. During the initial phase we had because of delayed HIV diagnosis and potential increase in HIV transmission within the community, especially mother-to-child transmission of HIV. There has been an increase in vulnerability with marginalized populations becoming more marginalized, and an increase in gender-based violence, particularly among women and children. Investments made to support HIV implementation have been leveraged to support response to the COVID-19 pandemic. Great innovations and strong evidence of resilient communities such as which will be showcased in the 3 days conference have also emerged, with people living with HIV supporting community distribution of antiretroviral therapy and rapid scale-up or multi-month dispensing to maintain continuity of treatment. Ladies and gentlemen, we are tackling a double and sometimes a triple pandemic, which is not easy. Amidst the COVID-19 pandemic, none of the HIV services was greatly affected. The HIV testing service continued within our facilities, but declined at the community level, as I said before. But our clients were able to access treatment where we would have like one of the people living with HIV going to pick drugs for other colleagues and they be able to go distribute it to other counties. Our country remains committed to the joint United Nations program on UNAIDS, that's the 2595 targets for ending the AIDS epidemic by 2030. But no, we are currently tracking our 1990 goals, where 90% of people living with HIV are identified, 90% are put on treatment, and out of the 90% put on treatment, they ensure that they have attained viral suppression. So far, overall, in terms of uptake for the whole population, we have been able to identify 79.4% of all people living with HIV. And out of the 96% of the ones we have identified have been put on treatment. And out of the 96% have been put on treatment, 88.4% have achieved viral suppression. As at the end of 2020, in terms of uptake, we were at 80% being identified, 90% on treatment, and 94% of the ones on treatment. Our gap remains among the pediatric population, where only 79% have been identified, 93% have been put on treatment, and only 67% are virally suppressed. But we also remember that apart from the 1990, we have other challenges. First, and as I was saying, triple pandemic, teenage pregnancies. Colleagues, I think that's an area where we are as a country, we need to look at HIV and other issues holistically and comprehensively. We have noted with increased teenage pregnancies, as well as increased new HIV infections, and as well you have noted increased mother-child transmission of HIV. As well, psychosocial support. I think we addressed it at the beginning and we came a point we lacked on it, and I think it's time we go back and have psychosocial support admitted and be able to support our people on it. I really want to applaud the many researchers, especially from Cambridge institutions, teasing out Professor Mbukusi and Neri Mugo, who for the last 1 year have brought to our attention the increased other sexually transmitted infections, especially chlamydia and gonorrhea, among our young girls who are between 15 to 25 years old. We have noted 29% increase of chlamydia and gonorrhea. And let me tell you, yes, you have treatment for it, but more so I'm worried of infertility. So in the coming years, we will have other pandemics caused because of other sexually transmitted infections that I think we have neglected. As a country, And as a government, we are committed to the elimination of mother-child transmission of HIV on new infections. We know right now we are at 10.9%, and we hope by 2024 we'll be less than 5%. We are working collaboratively with other stakeholders in ensuring that all women infected during pregnancy and breastfeeding are aptly diagnosed and put on treatment, and they continue with their treatment, their pregnancy, breastfeeding, and beyond all. All exposed infants are put on prophylaxis. Over the years, we have evidence that when HIV-infected infants are identified early and started on lifelong antiretroviral therapy, they live and thrive to their full potential without being limited to the HIV status. We boast as a country our great success, which is attributable to many factors, one of being the excellent partnership we have with our county governments, collaboration with bilateral and multilateral agencies, a multi-sectoral response with a strong health sector leadership, and strong political commitment from our leadership. And as I finalize on my final remarks, I really want to appreciate the chair of the board, the Cabinet Secretary Mutahi Kagwe, the Principal Secretary Madam Susan Muchache, CEO NACC, Parliament, Treasury, and His Excellency for increasing the government allocation. We have been, because of the 3 diseases, not only 5.8 billion. So in the year 2021-2022, the government has allocated 9.7 billion to HIV, TB, and malaria, which is a very, very big achievement. But still, with the key gaps remain, we strive to offer the best quality of services to the PL-HIV in our country in the space of reduction of the funding, and I'm really grateful to the government for the allocation. As we battle these pandemics, among others, I urge all of us to remain committed to providing equitable, affordable, quality health care of the highest standards to our fellow citizens. I hope that during these days of consultation with all of you, our conversation shall help us to identify opportunities to design and support tailor-made interventions for improving HIV and other sexually transmitted infection services in Kenya, because the buck stops with us. With these remarks, all people living HIV must survive to thrive. I wish you all the best, and thank you, and God bless you.
Thank you. At this moment, I would like to introduce Dr. Rudy Eggers. Dr. Eggers was engaged as the National Immunization Program Manager in the National Department of Health of South Africa and headed major programs changes during this time, including the change of the vaccination schedule, the introduction of Hep B and Hib vaccines into the program, and the implementation of polio and measles campaign. He then served as a team leader for the WHO immunization intercountry program in Eastern Africa in Nairobi, Kenya, supporting immunization programs in 8 East African countries before he joined the WHO headquarters in Geneva. As a team leader of the immunization services, strengthening in the Directorate for Immunization, Vaccines and Biologicals in the year 2005. In WHO, his current work is focused on providing guidance to improve immunization and coverage and to strengthen immunization systems, especially lower performing countries. Ladies and gentlemen, let us put our hands together for Dr. Rudy Eggers.
Thank you very much, and let me start off by recognizing some of the distinguished guests. Of course, our chief guest, Dr. Mercy Mwangangi, the CAS of Health, but also Madam Angeline Shiparo, the chair of the board of NACC, Professor Anyang Nyong'o, the governor of Kisumu, who chairs the health committee, Professor Kenneth Ngure, chairing this meeting, of course, Dr. Mark Maxwell, the representative of the UN government, US government. Then from the UN agencies, Dr. Winnie Yima, the Executive Director of UN AIDS, also represented here by Dr. Medin Chehai, who is resident here in Kenya. Dr. Ruth Laibon Masha, the CEO of NACC, who we heard on the online. And let me just also welcome Ms. Ruth Limo. I think it's absolutely astounding the passion that she brings to this conversation. So thank you so much. Distinguished guests here in the room, in Kenya, online, across the world, good morning. Habari Yasibui. Today I'm actually standing in for the WHO Director General, Dr. Tedros Ghebreyesus, who was invited to this very important meeting but was not able to come. So on behalf, I'm very happy to speak to you today. Let me present to you the remarks from WHO. This is a very important meeting at a decisive time for HIV/AIDS in Kenya and for the response of the global HIV epidemic. As you know, the COVID-19 pandemic has caused severe disruptions among many essential services, including the disruptions to the HIV control. This threatens to unravel some of those gains that we've made in the past years, and it threatens to derail the Sustainability Development Goals. Against this background, the Global AIDS Strategy 2021 to 2026 was adopted last week in the UN General Assembly high-level meeting on HIV/AIDS. This is very important because this high-level meeting comes at a historic time of the AIDS response, namely 40 years after the emergence of that first HIV case. The countries at the high-level meeting on HIV and AIDS adopted a political declaration in order to get the world back onto track as AIDS as a public health threat by 2030. Recommitting to urgent action over the next 5 years, the member states agreed to the following. Firstly, to reduce the annual HIV infections to under 370,000 and annual AIDS-related deaths to under 250,000 by 2025, ending pediatric AIDS and eliminating all forms of HIV stigma and discrimination. Secondly, to achieve the 95-95-95 testing, treatment and viral suppression targets within all demographics and groups and geographic settings, including children and adolescents living with HIV. Thirdly, ensuring that by 2025 at least 34 million people living with HIV access to medicines, treatments and diagnostics. Fourthly, to ensure that 95% of people at risk of HIV infection are protected against pandemics. Fifthly, to eliminate all forms of sexual and gender-based violence, including intimate partner violence, by adopting and enforcing laws that address multiple forms of discrimination and violence faced by women living with, at risk of, and affected by HIV. And then finally, to ensure that 90% of people living with HIV receive preventative treatment for TB and reduce AIDS-related TB deaths by 80% by 2025. You can see these are very ambitious targets, again, getting the full political will. Over the last 2 years, the number of new HIV infections globally have only slowly reduced to 1.5 million annually, and there was a stabilization of AIDS-related deaths at 690,000. And while millions of people now have access to ARVs, global targets for prevention, testing and treatment are off target. WHO is concerned that the progress is stalling because HIV protection, prevention and testing services are not reaching the groups that need them the most. Addressing these challenges will require a people-centered approach with comprehensive and integrated health services that address all the needs of the whole person. That is why WHO's top priority is supporting universal health coverage worldwide and especially here in Kenya. We are encouraged that it is based on strong primary health care with an emphasis on promoting health and preventing disease. Working together in solidarity, we can get back on track in ending the AIDS epidemic and build a healthier, safer world for all of us. As stated, the world needs to intensify efforts to end AIDS as a public health threat by 2030. This is especially true given the disruptions of the current pandemic. We have the tools and guidelines, and now we have a new strategy that will set the tone towards elimination of these new infections and reducing the burden of AIDS. The Global AIDS Strategy and its 2025 targets will help align the work and strategies of all, the implementers, the co-sponsors, and the partners. The strategy provides an important multi-sectoral framework to accelerate the progress towards our 2030 targets. We welcome the strategy's focus on intersecting inequalities to address the remaining challenges ending AIDS. The strategy describes interventions that require urgent prioritizations in the coming 5 years and the communities where efforts should be targeted, including key populations, women and girls, and the millions of people living with HIV who are still unaware of their HIV status. It outlines the importance of ensuring that HIV prevention efforts reach all people from key population groups, including men who have sex with men, transgender people, people who inject drugs, and sex workers and their clients, all of whom are higher risk of exposure to HIV than other groups. And it highlights the needs of focus on other priority populations, including adolescent girls and young women in sub-Saharan Africa, and children and adolescents who lack the opportunities to access dedicated services they need. The strategy inspires an ambitious vision for ending gender inequality and realizing human rights, including the right to health, calling upon all partners and stakeholders in the HIV response in every country to transform unequal gender norms and end stigma and discrimination. And as was highlighted before, it calls for better data, for identifying the gaps that we are facing and stronger links between community-led responses and primary health care that is needed to address these. We would also like to express our appreciation to all the people, the many people who have championed the cause for decades, including people living with HIV and also members of the program coordinating board of the NGO delegation. In addition, WHO is also developing a new global strategy for HIV, hepatitis B, and STIs. As was mentioned a minute ago, STIs are a very important component in this. And this strategy will outline the path to reach the 2030 SDG goals with the strategies. As the pandemic has disrupted delivery of vital services, it is setting back the global effort of many health programs, including those to end HIV and AIDS. The health and community workers who provide the bulk of the HIV services now find themselves battling not only HIV, but COVID. A record 27.4 million people are now on life-saving antiretroviral treatment. While this is good progress, it leaves 10 million people who are living with HIV but are not receiving treatment, million people who have not been diagnosed. This includes health and community workers who are themselves living with HIV. Nevertheless, thank you to the untiring work of the health and community workers the number of countries reporting disruptions in AIDS and in HIV services has declined by almost 75% since June 2021. Only 9 of the 152 countries surveyed are still reporting ARV disruptions. The number of countries reporting a critically low stock of ARVs has been reduced by half since June, but 12 countries still need urgent resupply of these life-saving medicines. We've seen many new approaches that countries are adopting to ensure HIV care during the pandemic. For example, providing multi-month prescriptions of HIV medicines, which Kenya has previously adapted and implemented. We are seeing other mitigation services in response to the disruptions, including the scale-up of HIV self-test kits to aid the disruption to HIV testing. This strategy is also being used in Kenya. Ultimately, our fight is not against a single disease, but our fight is also against the extreme inequality in health, both in health services, in health access, and in health quality of services. Our fight is against the inequity in which people get sick and die simply because they are poor, or female, or young, or gay, or transgender, or are sex workers, or use drugs, or are in prison. In WHO, we are committed to fight against health inequality in all its forms and are committed to health for all. With those few words, let me thank you for allowing me to speak on behalf of WHO in this important meeting. I really wish you a productive discussion. Thank you. Asanteni.
Asante sana. Thank you very much. The Chief Executive Officer, Charles Lyons, has led the Foundation through significant changes to the programmatic and advocacy portfolio of work. This organization transition centrally managed globally awards and managing the broad range of bilateral awards in a dozen countries. Ladies and gentlemen, I now introduce Chief Lyons, who is coming to us virtually to make his remarks.
For Health, Ms. Angeline Saparo, National AIDS Control Council Chairperson, Professor Anya Nyango, County Governor and Chair of the Health Committee of the Council of Governors, fellow panelists, invited guests. I'm honored by your invitation to be with you this morning and pleased to share some remarks on ending HIV among children and adolescents at this important conference. In fact, we are encouraged and confident that together we can secure an AIDS-free generation for Kenyans and for people around the world. We have the tools to do so, but to really achieve our aim, we need real leadership and dedicated resources that prioritize children. Based on recent national data from Kenya, we see that in 2019, 6,800 children were newly infected with HIV, representing 16.4% of all new infections in the country. More concerning is that 61% of new HIV infections were among adolescents and young adults between 15 and 29 years. It was not unique to Kenya. Globally, recent data indicates that a staggering 150,000 children were newly infected in 2019, meaning the world has significantly missed targets set for preventing new pediatric HIV infections to fewer than 20,000. Pediatric HIV infections are on the rise in a handful of countries. Pediatric treatment coverage has stalled, and countries and partners have failed to identify and reach almost half of the children living with HIV. We at EGPAF, and I know each of the organizations represented at this conference today, are committed to the goal of ending AIDS as a public health threat by 2030. But it is clear that we are sorely off track. only be met if we work with serious purpose and innovation to get the greatly improved prevention tools, medicines, and knowledge to those that need them most, while doing so in the context of protecting rights and ending stigma. Approach must extend to children who are never quite viewed in the same light as adults living with HIV. Without a voice in the response, children themselves. And so it falls to all of us to put children forward, them from once again being left behind. In important ways, you did so just last week at the National Multi-Sectoral Consultation convened by UNAIDS, NACC, and faith-based organizations. NACC has the opportunity to hold across the continent, where 90% of children living with HIV reside. Yet one can almost get a sense of complacency on the pediatric HIV agenda, one that we must resist. For example, we must address with urgency that there has been a plateauing in the reduction of mother-to-child transmission in Kenya since 2015. Including the impact HIV has had on Kenya and on the people of Africa, makes ending AIDS in children and youth almost by definition a Kenyan challenge and an African challenge. Leadership, your example of progress, and broadly requires African-led solutions with international support. It's on Kenya to continue leading the way in adapting tools, new technologies, and drug formulations and research to ensure children and youth are not left behind, even in the face of COVID-19. Under the leadership of the esteemed individuals and organizations gathered here today, we can drive action on rapid development and rollout of pediatric diagnostics and treatment of HIV. This includes use of early infant diagnosis. This is an innovation we know works, and we need to bring it to scale. It is crucial to immediately initiate infants born more likely to become gravely ill and die within the first 8 to 12 weeks of life. We need to speed up the adoption of cutting-edge pediatric diagnostic tools and affordable and we really need to engage and support communities to support children outside of the facilities. Our experience has shown this is a critical step to closing the gap between children and adults. Realistically, if we can't end AIDS in children, what chance do we have of reaching the 2035? In fact, AIDS in children can be ended in Kenya and on the continent, and with the improved tools and knowledge we now have in hand. We're at a moment where the question really is, will we collectively choose and act to do so? Elizabeth Glaser once said, sometimes children, mothers, and families everywhere, driving tangible change on the technical approaches, the political will, community strategies, and resources needed to get the job done. You have my very best wishes for a most productive conference and exciting actions outlook. Thank you so much.
Thank you so much, moderator. Yeah, chief guest, CAS Mwangangi, Madam Siparo, the board chair, Dr. Catherine Ngugi, head of NASCOP, our young people representative, PEPFAR representative, Max, the conference chair, Professor Nguri, NACC leadership, government representatives, conference participants. Thank you so much once again. Yeah, let me start by congratulating the government, especially NACC, for organizing this important conference and bringing us together to review how have we done in terms of the AIDS response, and now review, learn, and innovate, because the key word for today's conference is innovation and resilience. So it's very important to highlight what we want to innovate in terms of the policy, strategy, but also the implementation, so that Kenya can accelerate its response and end the AIDS and inequalities. Thank you, Dr. Rudy, for elaborating the global AIDS strategy. You know, yeah, we speak the same language. We are one UN family, but not only as UN, all of us are speaking the same language. So we have the high-level meeting, political declaration, which I won't go into details because I have my regional director online to represent our executive director, Ms. Winnie Byanyima, to deliver her statement. But taking this opportunity again, I want to congratulate Kenya, especially for allocating resources now for HIV, TB, and malaria for the first time. And we hope this domestic financing as part of the innovation will continue and grow until it is fully owned by the government and the nation. So with this brief introduction, I have Mr. Enes Chuma, our regional director for Eastern and Southern Africa, online to deliver our executive director's remark. And thank you very much for the opportunity. So I pass on the floor to him. Thank you.
For the feed.
Yes. Can you confirm that you can hear me? Because I can hear you. Hello?
We can hear you very clear.
Oh, okay.
Go ahead.
Thank you very much indeed. Thank you, Mr. Moderator. Let me acknowledge the Chief Guest, Dr. Mercy Mwangangi, Chief Administrative Secretary, Minister of Health. And also, if you agree with me, I'll just make the observation that all protocols observed in the interest of saving time. As mentioned by Nadine, my name is Enes Chuma, and I am the Regional Director for UNAIDS, and I'm going to make a statement on behalf of Dr. Winnie Byanyima, who was invited but is not able to join at this point. It is indeed a pleasure to be with you today on this very important and timely conference. I think some of you may be aware that just over a week ago, we commemorated a somber anniversary, 40 years since the first reported cases of AIDS. Since the start of the epidemic, more than 77 million people have become infected with HIV, and almost 35 million have died. We are at a critical moment in the AIDS response, and this Maisha conference, focusing on the last mile, resilience, and innovation, is particularly timely. Last week, United Nations member states came together at the UN General Assembly and adopted a new political declaration on HIV. We're grateful for Kenya's active participation in the high-level meeting events, from the statement of Dr. Aman in the general debate on behalf of President Kenyatta, to strong Kenyan participation in the side events on faith, on young people, and on sexuality. The new political declaration is a roadmap for the next 5 years, a globally agreed plan to end AIDS by 2030. It is ambitious and, most importantly, achievable. It includes targets to achieve by 2025, prepared by UNAIDS and drawn from the Global AIDS Strategy. a golden thread through the new strategy and the political operation is ending inequalities. The targets are inclusive, they are progressive, and will save lives if all countries reach their targets. New infections will be reduced by 75%. The number of people dying from AIDS-related illnesses will be reduced by around 65%. If countries continue business as usual, however, we will fail. The programs that have secured substantial progress will not enable us to finish the journey because the road is blocked. The evidence analysis is clear. Inequalities are driving the HIV pandemic. The very people most affected by HIV, men who have sex with men, sex workers, people who inject drugs, transgender people, and people in prisons, are being left out of health programming and vulnerable to HIV. The political declaration includes important targets and commitments to break down these barriers and reach 95% of people most affected with HIV prevention and treatment services. There are also important commitments for women and girls. In sub-Saharan Africa, around 4,200 young women and adolescent girls aged between 15 and 24 are infected every week. And 6 out of 7 new infections, HIV infections among adolescents aged between the ages of 15 and 19 are among adolescent girls. We need to ensure that all girls complete secondary education and are empowered with a full set of services and rights. Member states have also committed to increase and fully fund the AIDS response, investing $29 billion annually by 2025 in low and income countries will save lives. As Kenya moves into middle income status, we also need to find ways of increasing domestic financing for the HIV response to ensure sustainability. I applaud the government for allocating 47.7 billion shillings from its 2021-2022 annual budget for UHC that includes 5.8 billion for addressing cases of HIV, TB, and malaria. I applaud Kenya's AIDS strategic framework, which incorporates the latest targets. UNAIDS looks forward to working with you and your civil society partners as we implement the political declaration. We must work hand in glove with our friends and allies in communities. Community-led and community-owned approaches are absolutely key to address intersecting inequalities and bring us closer to our goals. The inequalities exposed by the colliding pandemics of HIV and COVID-19 are indeed a wake-up call for the world to prioritize and fully invest in realizing the right to health for all people. And I commend the efforts of the Kenyan government to continue to not drop the urgent fight on HIV while fighting COVID. Thank you for your steadfast leadership on rolling out universal health care as well. In closing, I wish you successful deliberations over the next few days. Together, we can end the inequalities that fuel new HIV infections and that keep people away from health services. At UNAIDS, we look forward to working with you very closely and to the outcomes of this conference. Let's keep the fight on. I thank you for your attention.
We are almost there, so don't tire. At this moment, allow me to introduce Dr. Daniel, Country Director, President Emergency Plan for AIDS Relief. represented here by Maxwell Marks, Senior Advisor and External Relations, going to make his remarks and thereafter invite Dr. Towns.
Happy Monday. You don't all sound happy. CAS, Ministry of Health, Dr. Gangi,